this parable, here I open a space in a provisional tooth, and this opening of a space allows us to see the hematrix and the vessels, which tend to migrate towards the coronal part. Now these vessels will will intensify, almost wanted to create a new circulation there, and slowly this will support the final outcome. The final outcome, which is the appearance and the growth of tissue that goes towards the coronal part. Actually, one of the things that surprised me many years ago was the growth that I could obtain through this technique. The growth of the tissue, therefore, a coronal repositioning of the tissues in the areas that to us were a taboo. So it was impossible for the tissue to go towards the coronal part after a prosthetic intervention. It was something inconceivable before the introduction of this type of procedure. Especially, there were the issues were the other way around. So recessions, which could take place exactly in the marginal area of our crowns, treated with the finish line. But what happens is the growth of tissue in this space, which many times allows the thickening of the tissue and the repositioning towards the coronal part. Of course, when this is needed, when it is not needed, because there are no discrepancies to fill, the technique only allows to increase the thickening and a stabilization of the tissues there, which lasts over the years. If we compare the two preparations, the vertical one and the horizontal one, we can see that the horizontal preparation must be considered, at least for me now, and I did use it for a certain time, it can be considered a preparation that is static. But actually, horizontal preparation is just a technique in the creation of a space in the tooth structure, which will then be filled with our restoration. And this is a technique which is static, because the thickening we create cannot be then changed. We cannot interact with what we have done on the tooth unless it is through a re-preparation, which anyways will always go towards the apical part. So the change in the volume in the space always happens inside the tooth structure, and we can change it only by re-preparing the tooth. This is why a restoration in these situations is a static restoration, because it cannot emerge in a different way than the volumes we already have described with our preparation in our space. Because the finish line, the space we create, is on the tooth. What is completely different is the vertical preparation, which I consider as a dynamic preparation, because there are no lines. Since the line is transferred to the tooth, it can be changed at different levels. And since there is no thickening structure in the tooth, and we have the volumes in the restoration transferred only to the clinical crown, we can play with the volumes, also starting from especially small volumes offset with our restorations, or in other situations starting from particularly big and bigger volumes. We can change the volumes of the crowns, always using our restoration in a different way on the vertical preparation. So on the vertical preparations are dynamic, and the restoration, I think, is an interactive restoration, because through this change in volume and position in the tooth structure, I can interact with the tissues, and I can change them, and I can transform them, and I can interact with the papillas, with a whole series of issues which are usually treated in the traditional prosthetic treatments, is not treated by the prosthesis, but through gingival or resective surgery, which is used to manipulate the tissue, which cannot be manipulated by aesthetic restoration. And this is possible because in vertical preparations, the finish line is not on the tooth, it is on the crown. So we can modulate it in a different way. You see here, vertical restorations here where the emerging volumes and the line are only on the crown. So we start from this concept and we can see these two central teeth, for example. If I were to ask you, what's special? How different are they? These two central teeth. Well, not much. There is a papilla, which is more coronal than the lateral papillas. And actually, there is a certain symmetry of the parable, so nothing really different. But actually, they are different because these are not two central teeth. They are two central teeth from a prosthetic point of view in terms of the restoration with the BOPT technique. But actually, if we see the starting of these two teeth, we see that the one on the right in the image is actually a lateral. So through a vertical preparation, we were able to recreate two central teeth that are pretty symmetric with the formation of a papilla, which couldn't exist because from a crustal point of view, it is not there. So you see here, during the cementing, and then over time, the evolution of the tissues would tend to go towards the coronal part. So BOPT is the technique that actually allows to treat situations which otherwise would require multidisciplinary interventions. Like, for example, here. What's special about the lateral incisor on the right? In the image, we see it on the left. So what's different? How is it different from the contralateral one? Actually, not much, apart from the fact that the lateral incisor on the right is a canine. And so, treating this volume, well, this can be done through a technique, that is to say BOPT, which allows a vertical preparation and the transfer of the volume and the line only to the restoration. So with a transformation, in this case of a canine, into lateral incisor. So we have made some compensations. I mean, the person who worked here added a veneer on the contralateral to increase its volume. So to create symmetric volumes and realignments of the parables. As you can see here, also the parable on the canine responds with the shape of a canine, while the parable of the lateral one tends to go towards coronal part and therefore to realign with the parameters which are typical of a lateral incisor volume. So if we see these images and we talk now about the width, now here in biologic width, I see two components. One is touchable, I think, which is the free gum, the groove, and through our preparations and our restorations, we can intervene in the groove and therefore interact with the tissues. And then there is also another part which is not touchable. So this part is touchable and it can be considered as an area of freedom where, as we saw before, through when we saw those two cases before, with those volumes and with the finished lines, I can interact with this free part, so the part of the tissue, modifying and manipulating the shapes. We must always remember that the underlying shapes are the ones that change and dominate with the upper lying parts, so with the marginal tissues. So BOPT is a prosthetic procedure that is simplified, which uses vertical preparations to be able to be done. What are the benefits of the technique? We should distinguish from clinic and biologic benefits. One of the clinical benefits is the freedom in restoration, so the possibility to go, as you see here, from the finish line and the thickness we treated with the vertical preparation. So this changes the possibilities to interact through the vertical wall. So with our preparation, we can erase the emerging anatomy of a tooth, or if the tooth has already been treated with finish line, we can eliminate that, creating a vertical part, and we can intervene with the position at different levels of upper line based on the invasion of the groove and the volume we need to interact with the tissues. So the change in position and the possibility to remodulate different profiles and emerging angles, different ones, so we can have different degrees depending on what we need with the interaction of the soft tissue, so with the creation of a remodeling, what I call prosthetic adaptation profiles, where we propose new shapes so that tissues will adapt on those. And so intervening with these new profiles, with this new emerging anatomy, for a new adaptation of the tissues on these new things. So what happens with BOT? We transfer the line and the emerging anatomy that are present when we do thickening preparations on the tooth only to the prosthetic crown. We can prepare the vertical tooth, we can reintegrate it on the natural tooth, or with the prosthetic simulation, we can see that on the natural tooth. So creating a new CEJ, a new junction, which is a ceramic cement junction, which simulates the emerging anatomy of a natural tooth. The other great benefit is that the tooth preparation creates a space and becomes a part of the tissue. So when we prepare a tooth and we create spaces, then the gums will occupy those spaces, so it become thicker. So BOPT is a technique that changes the volumes and the thickness of the tissues. When I said that in the past, well, that was difficult, but now there is a whole series of clinic and scientific evidence corroborating this. So when we create the morphogenesis of the prosthetic element, we need to understand and develop a series of concepts to understand where we started from, to then create all of this. One of the important things, I think, well, must be clear, actually, before continuing with the technique, is understanding what an anatomical dominance is, what then I call, as a consequence, the prosthetic dominance. Because you know that the gingival shapes depend on the underlying shapes. So the dominance, anatomic dominance of the tooth shape is that dominance that shapes the upper lying tissues. The symmetries of gingival parables depend on the shapes, and it is the shapes which give us not only the space, but also the shape and the trend of the parables. So teeth have a capital importance for the underlying shapes, which will then shape the upper lying parts. So if we preserve with our preparations, so when we did the finish lines, if we preserve the CEJ of the teeth, we are actually preserving the anatomical dominance of these teeth. And therefore, we are preserving the shape of teeth, which will affect the shape of the upper lying parts. If we exceed the CEJ and we don't preserve this volume symmetry, we invade the radicular parts, so we erase the anatomical shape of that tooth, and so we go into what I call the prosthetic dominance. So tissues will no longer read the anatomical symmetries, and they will start to read the new prosthetic shapes, creating a whole series of discrepancies, as you can see here. We will see this case then. And in these cases where parables, and also the diameters of these parables and the heights change based on the new prosthetic dominance created by the crowns, which shape the tissues. So if we see the anatomical dominance, we can understand from these images what it is. So if we prepare under the anatomical CEJ, if we make the preparation under that, we preserve the anatomical dominance. So different preparations at different levels. This means the preservation, the symmetric preservation of our shapes. So the gums will remain symmetric, because we have not altered anything. We have not altered the shapes of the teeth. But this is different if we prepare our tooth exceeding the CEJ part, so erasing the natural symmetry of our volumes. So what happens then? It happens that the gums will read these new shapes, and since they will no longer have a symmetric shape to read, they will start to be displaced. So every time we oversee it here, since we are not able to prepare teeth in a symmetric way, our restorations will have different volumes, and so there will be a prosthetic dominance that will create exactly those discrepancies and those alterations of the symmetries of the parables, which usually in those who make the lines can only be treated through tissue surgery. What is different is the treatment made through BOPT. So when we talk about ideal preparations, we talk about preparations which must be done above the CEJ. But actually, what happens in clinical practice every day is that actually all the preparations, or at least most of them, since they exceed the CEJ, go from an anatomic dominance to a prosthetic dominance, and as you can see, then there is a series of discrepancies and displacements and apical displacements of the gums, and then what can happen for a whole series of reasons and contours, subcontours, abrasions in the marginal part, and recessions of the tissues. And again, here, they are usually treated with surgery to recreate a new realignment. We know that volume of the restoration, as I said, through prosthetic dominance, is determined by the perimeter of our preparations. For example, look at these two teeth. You see that one is wider, one is narrower, and the parables are completely different. And this is due for sure to preparations which exceeded the symmetric volumes, what we defined anatomic dominance, and they invaded the radicular part. And as we will see, this volume, which is then expressed by the tissues, starts from a different volume that is perimetral to the preparations, and also different trend. So it was the restorations that created a new dominance, which then altered the symmetry and volume of these teeth. So what treatment can we have here? And this is when we start to talk about BOPT. What are the treatments that we can use, for example, in clinical cases like this? These are cases which are usually treated through surgery. So treating the lower part to be able to realign it towards the higher part. And it is difficult with this technique lowering the tissues towards the coronal part. And so this causes exactly what I said before. Through the BOPT, on the other hand, by preparing these areas with vertical preparations, we can remove the inflammation that tissues had, which had led to the shape of the tissues. Through vertical preparations, we can recover in a coronal way the finish line. So through a preparation, we look for the wall, and as you can see, we create an area that will allow us to recreate restorations that can be symmetric. So they can give symmetry information to the parables to be able to be realigned. So you already see after 1 week how the provisional teeth realigned, in this case the parables, but we can also see how the tissues responded. So in the space where we have a narrower preparation, we have more compensation of gingival growth, and here where we have a preparation which is a bit wider, tissues have less thickness. What is important to see is that if we put this an emerging volume that is the same, the tissues respond in a symmetric way. So starting from these different volumes, we in the lab can introduce the concept of transfer of lines and volumes from the tooth to the prosthetic crown only, creating two symmetric teeth elements with a trend, with a marginal trend that is symmetric, which will influence, which will inform about these new shapes, the tissues, which will then realign, as you can see, in a symmetric way, also taking the parable towards the coronal part with this new realignment in the area of freedom of the groove we talked about before. So we provide new symmetric information to the tissues, and the tissues respond in this way. Actually, the essence of the BOPT, which of course has a bit more complex procedures in terms of the realization, is actually almost exclusively this. What is the biologic model from which we started to treat cases like this? Well, the starting biologic model is natural teeth, because we don't have teeth which have a thickness in nature. We have teeth that, if we look at them in a section, starting from the animal crown and the dentin, we see that these teeth are prepared in a vertical way. So the animal crown is located, is like put in a conometric way of our tooth prepared. So these parts are the contours of the emerging angles. These are not super contours. They are the contours of natural teeth. So the shape of teeth is fundamental to influence the symmetry of tissues, as we have seen before. So in nature, teeth are prepared vertically, and the coupling between the animal line and the vertical. This is the vertical preparation. So it happens between the line of the animal and the area of the cement. So this is transferred to the prosthetic crown. This is a case which is very telling, which tells you how we can recover our finish lines in also in especially difficult situations. So when we face these big discrepancies and other issues on these central incisors, usually before the introduction and the use of BOPT, we used to treat gingival discrepancies always with surgery. So we would prepare the gums in a surgical way to receive the teeth. Today, on the other hand, through BOPT, I prepare teeth so that gums will position in a coronal way, or anyways be stable there, and therefore prepare teeth to receive the tissues. This is a case of an old rehabilitation which is adapted. It is more than 10 years old, and here we will remove the crowns, we will prepare the teeth, and we will position provisional teeth. Actually, when I removed the crowns, I saw that in the probing, the two central incisors, well, I saw that the subgingival part presented some discrepancies. There were alterations on the surface which were not clearly identifiable and understandable through the probe. So I didn't have good, smooth walls beyond a finish line. I had a series of issues that were difficult to be identified. So I decided to put the provisional teeth, not treating the central incisors. Never treat in a flapless way, in a vertical way, teeth of which you don't know about the anatomy, internal anatomy very well, because this would cause damages and disadvantages, not advantages. So I started to put the first provisional teeth, I waited for the healing, and then I wanted to intervene on the two central teeth, where, as I said, I didn't really understand the situation. So you see here, after 4 weeks, how the tissues have stabilized. You see that there are discrepancies on the canines. With BOPT, we will lower the parables, we will recreate through a creep the going down of the tissues into the linear position and the right position. Opening a flap, as you can see, I found a disaster in this preparation. We have chamfers which had been prepared. So you understand that to recreate chamfers, well, we, after preparing the teeth, we would already lose, from an apical point of view, we would lose part of the teeth. So we would have to create, through resective surgery, a preparation of the bone crest, which would displace by 3-4 millimeters from this. Of course, this would cause a great elongation of the teeth and an involvement of all interdental spaces and creation of black spots, black holes, but for sure not an aesthetic outcome, because here, if we treated these teeth with chamfers, then we are obliged to move the crestal part at a certain distance from the finish line. So what we will do with the resective technique, we will create a biologic space towards the crestal part. But if we use the BOPT technique, so the vertical preparation, we can recover the width, no longer towards the apical part, but towards the coronal part. As you see here the chamfers, but the parables are intact in time, in spite of a situation like this. If we want to recover towards the coronal part, what we need after the root canal treatment, we need to recreate a build-up of the teeth, which would allow us, after reacquiring a certain volume, to prepare these teeth, eliminating all the finish lines here, for example, and the defects, recreating vertical walls without involving the crests, so that with the finish line, now we can go back to the coronal part. So distancing new CEJ by 3 or even more millimeters from the crestal structure, but towards the coronal part. So recreating a space so that the width recreates towards the coronal part. This is actually the BOPT technique, and this is what allows us to manage tissues in a very simple way without doing resective surgery or big resective surgery. We had to do surgery here only to open a flap. This is a flap that allows us to see what was underlying without resective. So this is an exploration flap. We waited for the healing. We lowered, as you can see here, our parables so that the groove would start to go down, and we prepared the second provisional tooth, allowing for tissues to heal in a symmetric way. So recreating a realignment of our parables without any type of elongation of the teeth. As you can see here, what we have prepared in terms of space becomes part of the tissues. So we have a great thickening of the tissues. And so we can finalize, and this is an adapted case, but this is to show you through metal ceramic the results that can be obtained, and especially the maturation that in over time tissues have. So with the new shapes of the papillas, symmetries, which this takes place over time and stabilizing the tissues themselves. So why should we prepare and then in a vertical way and a flapless way? So why did I go from finish lines to vertical preparations and then the BOPT, restorative BOPT? Well, why? The reasons were mainly two, because the issues I always had were these. And any preparation with a finish line can be corrected only re-preparing the tooth towards the apical part. So if I prepare the line, I will create again a further displacement of the parable towards the vertical. But if I eliminate the finish line and I create a vertical wall, through the provisional teeth, I can reposition towards the coronal part, the new prosthetic CEJ, so that the tissue will thicken and grow towards the lower part. And this is important from a therapeutical point of view. We can treat many cases which usually were treated with resective surgery. Well, the other reason which led me to use this technique this is what led me to have flapless vertical preparations. It is the fact that when we have to face preparation which created, as you can see, disalignments, we need to try and understand what part was involved by these displacements. And for sure, of the two parts that I considered of the biologic space, it's the one we talked about, the part in the groove, so the one that can be probed, free gums that are involved by recessions. So if I have to treat these parts, I must not treat the crest with a resective surgery. I must treat the volume part of the restorations, and so the incongruous prosthetic teeth which created this problem. So I will have a vertical preparation, I will put the provisional teeth realigned, which will lead the tissues to reposition in the correct area, and then I will create a restoration through crowns that have a finish line and symmetric volumes in the central ones and the lateral ones, And after creating this in the first model, I will transfer in a second model, and here I will be able, through the BOPT in the lab, I will have realigned the parables, which then after these volumes of the shapes, this will be transferred. So in the cast model, we can treat with microsurgery that part of gums which can be treated through these new shapes we have created. In the biologic structure of soft tissue, so through our restorations, we will we will shape our parables, also introducing some zenith. We will affect the tissues with more stability and more thickness and more aesthetics. So after some time, after a provisional cementing, we remove our teeth. We can see exactly what happens in these tissues. In this case, we were lucky. The patient did a provisional cementing, and she was supposed to come back in a month for the pictures and then for the cementing, but actually she disappeared. And after 1 year, a tooth had started to move. It was discemented. So it was nice because we were able to see the tissues after 1 year. When we discemented the teeth, you see the parables, and you see the microcapillaries in the marginal area on one side and the other. And here you can see the increase in thickness of the tissues in the central tooth and the lateral tooth. And here you see all the microcirculation. And with this image, I would like to thank you. Well, I'm sorry, maybe I made many repetitions, but it was really difficult in 30 minutes. It's the first time I've talked for 30 minutes about this technique, so it's really difficult sometimes to be clear on a whole series of things. So thank you for your time. And now I give the floor to Giorgio, who will be tackling and who will be talking about conservative technique. Goodbye to everyone. Hello, my name is Giorgio Azzeri. I am a dentist in Oglio, a small town in Sardinia, and I have been working with Dr. Ignacio Loi, and I'm involved in veneers and reconstructions in class 5. And this is what I'm going to talk to you about. Now I'm going to share my screen with you. First of all, I would like to thank Tokuyama for this opportunity, and of course Dr. Loi for helping me in this professional growth. He gave me lots of insight and lots of ideas. I think that the BOPT is not only a prosthetic technique. He calls it an approach of simplified work. I think that it is more than that. So we are going to talk about aesthetics and BOPT. Aesthetics is based on a balance between hard tissues, the smile and the lips, and also hard tissues and soft tissues and the gums. In this case, for example, the patient came to my practice because he had seen that in a short time, actually 2 years ago, 2 years before, he had done this job, and the relationship between soft and hard tissues had been altered due to the position and the inflammation. So what we did was approaching in a very simple way with the BOPT technique these crowns on natural teeth, and with the implant, and also the veneers on the canines and the premolars. So with this type of approach, we were able to recreate a right balance between the hard and the soft tissues. Now, but this thing, of course, must be stable over time. And we saw, as Dr. Loi showed us, for this applies to prosthetic teeth and implants. But we need to see whether this is also true for classes 5 and veneers. So we need to have stability because we need to ensure an aesthetic result over time. So let's start from instability. Instability derives from the fact that many times there are marginal imprecisions of prosthetic jobs, for example, the accumulation of plaque and retraction. And this can be related to the fact that gums have an imbalance also from a chemical point of view, or an occlusal imbalance, or an imbalance related to the brushing, or an infection. All of these things are characterized by something more important, that is to say, the inflammation. All of these processes, the movement of the gums, are always characterized by inflammation. Inflammation is that process that defends us by external damage, and this inflammation can be related to a sphere, because inflammation cells go and surround our external damage, like in tissues, like in gums, in a spherical way. Because inflammation cells surround completely this pathogen. According to some authors, if this sphere, in terms of volume, exceeds the gingival volume, then gums will have a recession. And this is why the gums create those class 5 recessions. Then it is not clear whether it's first the problem on the tooth or it is first on the gums, but we know that we have retraction. In this case, we didn't have any retraction because the periodontal tissue was very thick. But in this case, it is even thicker. There is a lot of inflammation, but the periodontal tissue is very thick. So the problem is ensuring patients like this, with a very this type of tissue, we need to give them stability. So let's start from this image, which shows us how these teeth that are more prominent, like central ones and canines, had recessions because there is even though the periodontal type is thick, but then there is the phenotype, which also depends on the life of the patient. So the displacements of the teeth in a palatal way caused an increase in the thickness of the gums. And we know that dental technicians simply move the teeth in the vestibule when there is a crowding, because this might cause an increase in a problem with the gums. So the BOPT technique is based on this, a movement which is a prosthetic movement by creating with the burr a space, and it is in that space and the preparation that a clot is created, which can be treated through the second principle of the BOPT, and through this shape we can contain the clot and lead to a filling of the space, creating a thickening, an increase in the thickening of the gums. So this formation of new periodontal tissue is at the base of the long-lasting duration of the prosthetic teeth. So even when there is a gingival inflammation, this increase in the thickness can contain a displacement of the gums. This is what we are looking for, an increase in the gingival thickness. This is true for prosthetic teeth and implants, where we have a lot of space, because with the burr we create a space for the provisional tooth, and with the implant, well, the implant, there is a lack of tooth, there is only gums, so we have lots of space where the shape can be used to move the gums. In this case, in prosthetic crowns and in veneers, actually he apologizes, in veneers and in classes 5, we have very little space. We cannot create space here because we have to have therapies that are conservative. So we have to preserve the tissues, inducing a movement. And this gingival change can only be achieved by the second principle of BOPT. So it's not space, but shape. So through a change in the shape and of the gingival profile, like in this case, we can induce a slight improvement of gingival trophism, therefore a volume change, which will be used by us when the patient, after some years, will no longer be able to clean. Like, for example, here, this is a patient that is hospitalized, so it's difficult for these patients to clean the teeth, but will not have a recurrence. And the same goes for veneers. This is a lady with periodontal problems, and there was a certain preparation of teeth, which led to the thickening of the gums in this way. After 5 years, we saw this even more so. So this gingival growth, which is induced by the shape and the space in this case, can only be induced by the shape, like in this case where we haven't actually changed the gingival margins of these preparations in these teeth. It's only through the use of shapes we have induced a certain movement, which is measurable through a scan. So that gingival volume is extremely useful for patients who are not able to clean their teeth. So here we have seen no recession. So it is now enough to have a correct hygiene, and there will be no gingival movement. What happens in classes 5 is the same. So classes 5 are characterized by instability. There is plaque, there is abrasion, and there is retraction. So the change in the volume of the reconstructions and of the emerging profile can lead to an improvement of the gingival status. This a patient who was not able to clean their teeth after 3 years. I don't know whether these gums have grown. Maybe there is a different orientation in the pictures, but what is sure is that we had stability of the gums, although the patient was not able to clean. So this is what we must do. We have to try and induce these improvements, these thickenings, and we can do this through a technique that I'm going to show you now in this video. As you have seen, what I did was changing the architecture of this gingival profile. I created a first increment, which then supported the gums, and then I filled the external part, creating a right relationship, which after 4 years is still stable, which then after 5 years is still stable, as we can see here. We didn't put the dam, but we still have stability in the relationship between composite and bondings and teeth. What we have seen now are classes 5, very quickly. These classes have, work more or less like veneers, because BOPT veneers also work, inducing a change, a certain stability in the dimension of the gums near the teeth. And this is what we have to try and do. We have to change the gingival architecture, determining a thicker phenotype which is stable over time. And here you see after 4 years, the patient, even though there are some small traumas from brushing, there are no recessions and no recurrence. This is what we can do in a periodontal case like this. So we don't change, we don't prepare the tooth in the subgingival margin. We can only use the shape, and through the shape we induce a displacement, a change in the volume, which is measurable through scans. So depending on the section, we have extreme increments, in this case from 0.4 to 0.9. And this is not related to the gingival inflammation, because these gums, even when they're probing, you see an intense probing, they don't bleed, and there is no type of problem. I'm now showing you in this video the probing. You see that there is no bleeding. Gums are stable, the periodontal tissue is stable. We only have an increment, which is usually easily measured. So this is what happens, the gingival change, which must depend on what we want to do. For example, the closing of these diastemas. After preparing the teeth, actually not preparing the teeth in the subgingival part, we use the shapes, we cement them. Space and shapes now are important. The space, what is already there, the shape is the one we induced with the new veneers. So after we take out the dam, the shapes readapt to the gingival volumes. So what we did was the complete closure of the gums, in this case with closing an extremely big diastema. So we change the architecture of the gums. Now we have a positive closing, a positive architecture, and a complete closing. This can be done with ceramic veneers, but also with composite veneers, where I try to transform by pushing this part of soft tissues, which is transform it into a papilla. So I reconstruct these parts of emerging parts, not only vestibular but also interproximal. I reconstruct this part. I reconstruct the body of the tooth and the margins, and in the end, this is the final outcome, which of course must be managed also through the polishing, where we can have retreat. This is the initial situation, and this is the situation after the gingival modification. So over time, these changes can be measured. Here we can see almost at a naked eye that there is a thickening, but you can still measure it. In this case, the dark part, the brown part, is the new part. We see here that in all the measurement points, there is always a small gingival increment, which is the guarantee of stability of our restorations in the relationships. So the preservation of tissues is our objective through this type of approach. And this can be done better than through a chamfer, because chamfers are a way with which we work creating a finish line in the point where the animal is thinner. So we really try to avoid doing this because we want to have a longer life of veneers, as this researcher said in this paper. You see that where we usually create a margin is the point where animal is thin. So by using this technique where there is no preparation in that part is a way to preserve the animal, and it allows us to preserve over time the thickness of the gums and of the animal, but also the long time duration. You see, teeth have been reconstructed in this case. This is the final result, but the problem is managing cases like this where there are overlappings, and also managing diastemas. Here, of course, it is a bit more difficult, and working with chamfers, we wouldn't be able to change the shape and the position of these teeth, especially along the sagittal axis. So the inclination of these teeth can be changed through this approach. You see, in this case, you can see this with the mock-up, and then through a calibrated cut technique, which allows me to preserve as much as possible the amount of animal and to keep it intact through the gingival margin, which is the fulcrum of movement, where the push forces from palatal to vestibular induced by the lower arch to the upper arch. These are the preparation of the teeth. These are the veneers. So by using these tools by Tokuyama, they are universal bonding for the teeth and for the ceramic, of course treated with etching before, and the various cements. This is after 3 years after cementing the veneers. This is done by Michele Orefice. This is when we started from, and what changes in the preservation of tissues, and again what the gingival change modification, which is measurable, measured through the scans, with the scanner. You see, even though it is slight, we always have a new increment, and this increment is done not only on the gingival limit, but also a bit in the upper part, in the fornix. Towards the fornix, this is the gingival modification, and this is our patient who is really happy of what we did. So I would like to thank you very much for your attention, and I would like to thank you, Tokuyama, again, Dental Tribune, and also I would like to thank everyone for listening. What I can do is keeping in touch with you with a Q&A and information. You can contact me through Messenger and Facebook with Smile Different, and also in my personal profile in Facebook. Thank you very much, and goodbye.